I'm Tsitsi Apollo, and I'll be chairing this session. The session title is What's Different About Differentiated Care and Service Delivery? I'm sure we've heard a lot about differentiated service delivery, so we want to understand what's different about differentiated care. So we have a number of speakers here, and I'm going to introduce our first speaker who's going to make his presentation. He's Dr. Brendan Brown from South Africa. He's a social scientist who's going to present on readiness for antiretroviral therapy, the implications for linking HIV-infected individuals to care and treatment. So he's going to make his presentation over 10 minutes, and then we're going to have 5 minutes for questions and answers before we move to the next speaker. Dr. Brendan.
Thank you. Good afternoon. This was collaborative research with colleagues from the Desmond Tutu HIV Center and from Brown University School of Public Health. Early linkage to care and treatment is key to maximizing the therapeutic and prevention benefits of ART, and therefore to the success of Treat All. In South Africa, Treat All was implemented in September 2016. The challenge now is universal access. Just over half of individuals who need treatment are on ART. The challenge is also early access. Several studies have shown that between 32 and 50% of ART-eligible patients are not initiating treatment by study endline. Rates of linkage to care are even poorer from community-based HIV testing services, such as mobile clinics and home-based testing. We know that mobile clinics help us reach undiagnosed individuals and are therefore an important component of Treat All. What we need to do now is learn how better to link these individuals to care from these services. We know that ART readiness can influence ART initiation. It also affects adherence outcomes. However, little is known about ART readiness at the time of HIV diagnosis and ART referral. It's important to understand the psychological drivers of readiness at this time to inform strategies to increase early linkage to care and treatment. And in the Treat All era, where diagnosis equals referral, we need to know and understand what are the immediate psychosocial barriers to care. Knowing this is important as we start thinking about differentiated care services at the front end of the HIV cascade. So our study aimed to assess demographic and psychosocial factors associated with ART readiness among patients referred for ART by a mobile health clinic in Cape Town, South Africa. The data come from the baseline survey of the iLink study, which is a pilot randomized controlled trial testing the effectiveness and acceptability of conditional economic incentives for ART initiation. Enrollment happened at a mobile health clinic operating in a resource-poor area in Cape Town. Adults 18 years and older who had never been on treatment were enrolled immediately after referral for ART based on a CD4 count at that time of less than 500. Fieldwork happened between April 2015 and May 2016 with face-to-face questionnaires administered by counselors. ART readiness is an abstract concept defined in multiple ways. Our measure was based on 3 elements drawn from the literature that are known to be required for readiness to exist. 1, an awareness that treatment will be beneficial. Based on the question, overall, how confident are you that ARVs would have a positive effect on your health? 2, motivation to initiate treatment. And 3, intention to start treatment soon. We also included a general self-assessment of ART readiness using the question, how ready do you feel to start ARVs? Our main binary variable of interest was a composite measure identifying individuals who reported very to all of these questions. We measured a range of independent factors, demographic, SES, health, and psychosocial. To point out a few, self-perceived health was measured by the question, in general, how was your health in the last week? Focusing on the psychosocial measures, we looked at knowledge about ART, perceived likelihood of testing positive, where the individuals had witnessed a positive ART effect, by which we mean the individual knew a friend or a family member taking treatment and believed it had a positive effect on their health. Also looked at the perceived likelihood of experiencing side effects, internalized stigma based on feelings of guilt and shame, perceived stigma based on the likelihood of being treated badly by friends, community members, health professionals, etc. We then measured subjective norms about ART initiation using the question, how many people like yourself start ART within 3 months? And we also finally looked at discount rates to get a sense of whether individuals were present focused. Multiple logistic regression models were used to assess factors associated with ART readiness. ART readiness was a binary dependent variable. We ran separate models for each of the independent variables controlling for gender, age, and education. Key sample characteristics to bear in mind: sample size was 87, 64% were female. The majority of the sample was under the age of 40 years old, and just over half perceived themselves to have been in good health in the previous week. In terms of ART readiness, we found that in all dimensions measured, a vast majority reported being very ready. 84% reported being very ready to start ART, 85% very motivated for ART, 89% very confident ART would have a positive effect on their life, 96% very likely to visit a clinic within 30 days, and 92% reported that they intended to start treatment within 30 days. In terms of our overall composite measure, 72% of the sample were identified as ready on all measures. Key psychosocial factors and prevalence to point out. Figure 1 indicates that self-perceptions of HIV risk are often highly inaccurate. 45% of males reported the perception that it was very unlikely they were going to test HIV positive on the day of enrollment. Figure 2, we see approximately a third of the sample believing that it was likely for them to experience side effects. Figure 3 and 4 show that both internalized stigma and perceived stigma were very common. And looking at figure 5, we see that just over half the male sample and a significantly greater proportion of the female sample knew someone living with HIV who was a family member or a friend who had had a positive ART outcome. Results showed that readiness was lower among individuals in good health and among individuals who did not think they would test HIV positive on that day. Readiness was greater among individuals with good ART knowledge and among individuals knowing someone who had experienced the positive health effects from ART. 3 factors showed large effect sizes, but were not statistically significant, and they point towards further research with larger samples. Internalized stigma was negatively associated with readiness. Beliefs about side effects also negatively associated. And intentions to disclose were positively associated with ART readiness. So in conclusion, our study shows that several psychosocial factors impeding ART readiness are common at the time of HIV disclosure, HIV diagnosis, and ART referral. Results indicate the need for interventions at the time of ART referral to deal with surprise at a positive diagnosis. The importance of this is underscored by the fact that denial is often a barrier to ART initiation. Future research could explore the effectiveness of counseling approaches to help individuals come to terms with a positive diagnosis. Interventions at ART referral are also needed to promote readiness among healthy-feeling individuals. Asymptomatic individuals may well perceive ART to be more of an immediate risk than an immediate benefit, especially given the high costs, some of which are exemplified in this study. So we really need to work on the cost-benefit analysis that patients are dealing with. Future research is needed on effective messaging on the multiple benefits of early ART. Finally, interventions could potentially leverage the personal experience of positive treatment effects to improve ART readiness, especially among men. I'd like to acknowledge the iLink study funders, the National Research Foundation of South Africa, and the South African Social Science HIV, the SASH program, my fellow investigators, and the collaborating partner, and especially to all the study participants, the Tudu Tester mobile clinic staff, and the iLink study field staff. Thank you. Thanks a lot.
Thank you, Dr. Brendan, for sharing insights into this important area of readiness for patients who are starting antiretroviral therapy, particularly in this era of test and start. So I would like to take some questions, some comments in the next few minutes, and therefore I would ask the House, if you've got questions, just go to the microphones on the sides of the room. So take all the questions and then get responses later on.
Hi, my name is Juliana from ICAP. I am sorry if I missed this, but I just wanted you to explain a little bit more how you identified and enrolled. Did you identify patients and enrolled on the same day, or did they have to go to the mobile clinic? So I missed that when you were in that slide. Thank you.
Okay, let's take the next question at the back.
Nancy Padian from UC Berkeley. Sorry if I may have missed this, but what is the association between readiness and uptake and readiness and adherence?
Okay, let's take one more question.
Thank you very much. I just wanted to know, what did you associate this readiness, the confidence in the RT? Was it knowledge? What was it? What was specific that came out from these people? Was it the national knowledge of HIV?
Sorry, can you repeat that, please?
Why do you think most of the patients, almost like 85, 90, were prepared and ready for treatment? Is it knowledge? Is it that HIV is now less stigmatized in South Africa? What exactly do you think, or do you associate that confidence?
Okay, we'll take one more and then we'll get the responses.
Ken Friedberg from Boston, thank you. We've moved a pendulum now from requiring 3 weeks, for example, of adherence education to data showing same-day ART start may be effective. And I'm wondering whether you would envision the next step of this being a 4 or 5 question instrument that people could ask at the time of testing positive to then differentiate and actually test whether there's a threshold for that score at which you would have the optimal outcome.
Optimal outcome of treatment readiness?
No, I've actually started using this as an instrument to test compared to not using it and seeing how people do.
Okay, Dr. Brendan, you can respond to the questions.
Thank you. In terms of study enrollment, individuals went to see to the test a mobile staff counselor. They were tested positive. Then they went to the trailer where the nurse conducted CD4 count testing, and individuals deemed ART eligible were referred for treatment. At that time, those individuals were introduced to the study and invited to go back to see the counselor for enrollment. So enrollment happened with the Tutor Tester counselors after they received their letter, which was referring individuals to the closest clinic.
I think the second question was about do you have any evidence that this being validating the readiness, that actually people who say they're ready or are deemed ready will actually initiate treatment?
Yes. So a number of studies have looked at this, and the evidence is mixed. Sometimes readiness is associated and sometimes not. A large part of this is to do with the fact that readiness has been measured in so many different ways. But with rapid ART initiation being promised or being implemented quite soon, the fact that readiness has been shown to be quite a poor marker of ART initiation is not that concerning to me in terms of having fewer ART readiness sessions. In terms of why so many individuals seem to be prepared for ART, the one factor could be that the counselors were really exceptional at the Tudu Tester mobile clinic. They had a really long time that they spent with the counselors, and then they went back, and yes, there's probably social desirability affecting the answers, but they went back to the counselors to fill in the questionnaire. That's my strongest hypothesis on that. In terms of the instrument for readiness, I think what my study highlights is factors which we should look at to help engage individuals immediately after testing positive that could potentially help with their ART readiness. As I said before, it's not 100% clear that ART readiness is a strong predictor of ART initiation, and it's also very unclear how exactly one would measure ART readiness in a really robust manner. So at this stage, I would not support the implementation of a screening or differentiated care based on a whole set of questions about ART readiness in itself.
Okay, thank you very much,
Thank
Dr.
you.
Brendan. I would like to introduce the next speaker, who's Julius Kiwanuka. He's from Uganda. He's going to make a presentation on factors associated with loss to follow-up in a primary healthcare HIV clinic practicing test and treat.
Thank you, everyone, for coming. My name is Julius Kiwanuka, and I work for the AIDS Healthcare Foundation in Uganda. So I'm presenting data here on factors that are associated with loss to follow-up in a typical primary healthcare clinic that is practicing test and treat. As we are aware, by end of last year, WHO had rolled out the 2016 guidelines, where the emphasis was on starting everyone diagnosed HIV positive regardless of CD4 and their WHO stage. But even before that, quite a number of HIV programs had begun scaling up HIV treatment, giving out ARVs, and the most important element was that most of them were challenged or have been challenged with patient retention. To our knowledge, there was little data in a typical clinic trying to compare or to compare loss to follow-up among clients who are beginning treatment instantly. I think the only experience that has been around is through the EMTC, the elimination of mother to child transmission of HIV. But obviously, this is not a typical setting because we understand at certain points these are interventions that are fully facilitated. So we set out to study factors that are associated with loss to follow-up in a primary healthcare clinic that had begun initiating patients instantly as far as 2012. The methods, we retrospectively abstracted data from an electronic records management system for all clients who are tested both at the clinic and in the surrounding areas through voluntary counseling and testing. And we included patients that started treatment through 2012 to 2014. We defined our test and treat as testing and starting ART on the same day, and the deferred mode as the otherwise. We defined loss to follow-up as failure of a patient or a client to show up at this massacre clinic for at least 90 days, taking 31st December as our administrative date. And what we did was to compare the cumulative incidence of loss to follow-up in these two groups, the group that started ART instantly against the one that delayed. We used the multivariate Cox proportion hazard regression to model the factors that are associated with loss to follow-up, taking or considering death as a competing risk. We sought ethical approval from the Makerere University School of Public Health and also engaged the clinic management where we abstracted this data. So the results at baseline, 50% of our study patients had started ART instantly. The proportion that were females was about 65%, and the median age at starting ART was 30.4. The proportion of patients that presented at baseline with a CD4, I beg your pardon, the proportion of patients that presented with a WHO stage 3 or 4 was 15.2%, and we also abstracted data on phone ownership or access, and this was in 43.5% at the baseline. We also found 7.5% at baseline to have been suspected or diagnosed with TB. And this is very interesting because, like I mentioned, these patients, some of these patients were actually coming through the different wards. So they would, in the test and treat group, some might have been diagnosed because they are coming in through the TB clinic. We compared cumulative instance of lost follow-up at 12 months. And what we found was that the test and treat group, the group that began ART instantly, fared badly when compared to the group that deferred treatment. In fact, the cumulative incidence of lost follow-up in this particular group was 12.3%, whereas the cumulative was 5.9 in the other group. And when it came to the factors associated with lost follow-up, we note that the mode of treatment is associated with almost 2.5 times the risk as it is in the deferred group. We note that phone ownership was protective. The risk was slightly, the risk in the test and treat, the risk in those who had phones was 0.5 times those that didn't. When it came to WHO staging, we noted that patients who presented with an advanced disease, that is stage 3 and 4, were at an elevated risk of becoming lost. And obviously, this would mean that they are ever bedridden, so they might find it very challenging to really come back after that first visit. And when it came to TB suspects also presented a 3.42 hazard rate of becoming lost to follow-up. I mentioned earlier that the definition of test and treat we used in this study was instant. Test today, start treatment today. We relaxed a bit about this definition and looked at starting ART within a week of a positive HIV diagnosis. But I can report that our previous results were again conserved here, because again, this group that began treatment within a week fared badly compared to the one that deferred. So in summary, initiating ART instantly, as we have seen, was associated with an elevated risk of loss to follow-up, and similar to advanced disease and TB suspicion. Whereas access to a mobile phone, and we've seen patients presenting with high CD4, were protective against becoming lost. And our conclusion, we are saying that in a bid to achieve the 90/90 campaign, the steep ART initiation should be backed by intensive pre-initiation and adherence counseling for better long-term retention of the patients. I acknowledge AIDS Healthcare Foundation. Thank you very much.
Thank you very much, Julius, for keeping to time and for that presentation. The floor is now open for questions. Let me take the prerogative to start. You mentioned the issues about access to phones and the association with the risk of loss to follow-up. Can you explain how that observed association? We'll take questions from this end first and then the other side. Go ahead.
Okay. Thank you very much, Julius, for your presentation. Dr. Ndulu is my name from Management Science for Health, Nigeria. I want to know if in exploring that the factors that contributed to loss to follow-up, was there a consideration for a distance to the clinic for the group that started test and start versus the group that were deferred? Thank you.
Okay, let's have questions from the right.
Thank you. John Stover from Evernear Health. I think my question is related. One of the reasons for loss to follow-up could be if somebody switched clinics and they didn't come back to that clinic, but they might have gone to another clinic. Were you able to capture that in your analysis? Because you might expect that people starting on the same day would have a higher rate of switching.
Okay, we'll take one more.
Yeah, thank you very much. I'm really intrigued. I don't know what went wrong. Are you going to redefine test and start now, treat all? Because the way it is, nothing worked for you. But I know in a situation where you have, if it's an HIV-aware community, they know about HIV. By the time they come to the clinic, most of them know their status and they're actually coming ready to start. And we find that when they do that, don't miss that opportunity. They come, they present, you start. And like I said, if there's a system that is in place to follow them up, it works very well. I come from Botswana, it's working very well for us. Thank you.
All right. Since you've saved on time, we'll take more questions for you. One more at the back.
Thank you very much. Hi, I'm Bill Reedy from ICAP. I have a question about how you defined the delayed ART initiation group, and specifically who you included in the tracking of loss to follow-up in your Kaplan-Meier and looking at your outcomes. Was it only from the point of ART initiation that loss to follow-up was tracked, or did you include people who were lost among that group who had not yet started ART? And if you did include them, if it's the latter, if you did include them, how did the curves look in comparison to each other?
Thank you, everyone, for these wonderful questions. The first one was on access to the phone and explaining the observed relationship. Now, in this massacre clinic, the idea is to really ask everyone who presents whether they can have access to a clinical, whether they have a phone, and if not, whether they can have access to a phone. And the reason this is done is before the clinic appointment, reminder SMSs are sent, and after a clinic and a missed appointment, someone is seated somewhere whose sole job is to call those who have missed appointment. So probably, we believe that this observed protective association could be explained by the fact that this specific group is actually called after missing an appointment, or they even receive a prior SMS before coming to the clinic. Distance to the clinic. Now, this study is fully based on data that has been abstracted from routine patient data. And I can assure you, this is not a variable that is captured by most of the health facilities. I think what I can positively confirm that is there is usually the village where you are, and it becomes a bit of a challenge to really estimate the distance. But I know it could, or it has a very, very big bearing on, someone getting lost or becoming inactive per se. Switching clinics, someone asked whether we factored in these transfer outs. Yes. In our inclusion criteria, we did not include patients who are transferred in from a particular clinic coming to this massacre clinic. And neither did we include those who are passing out, those who are transferred out. So at the end of the day, we included patients whose outcome we did not know. So if you are transferred out, we already know that you are receiving care somewhere else from a different clinic. So we did not include them in this sample of 600 patients. The fourth was redefining.
How do you describe the patients who were deferred at initiation?
What we did was a comparison of two groups. We got data on patients' testing date and their ART starting date. And what we did was, if your ART start date is the same as your test date, then we assigned you to the group test and treat. If it was the otherwise, then you automatically fall or fell in the deferred group. That is how we really defined this. Yep.
All right, thank you very much, Julius, for that presentation. I would like to introduce the next speaker, who's Sandra McCoy. She's from UC Berkeley. She's presenting a study entitled Pilot Study of a Multi-Pronged Intervention Using Social Norms and Priming to Improve Adherence to Antiretroviral Therapy and Retention and Care Among Adults Living with HIV in Tanzania.
Good afternoon, everyone. I'm delighted to present this slightly out-of-the-box pilot study on behalf of my co-authors at UC Berkeley, at the Tanzanian Ministry of Health, Community Development, Gender, Elderly, and Children, and the National Institute of Public Health in Mexico. It's well recognized that poor adherence to ART and disengagement from care undermine the effectiveness of treatment as prevention and other strategies to end the HIV epidemic. For example, 35% of people living with HIV infection in Africa have dropped out of care within 3 years of starting treatment. Traditional behavioral approaches to motivate people to stay in care or to be adherent to ART often rely on people's innate desire to remain healthy. These strategies include things that depend on information, education, and communication. However, these strategies often also ignore that decisions are influenced by emotions, contexts, and systems, as well as decision-making shortcuts that are often outside of conscious awareness. In contrast, the emerging field of behavioral science accounts for the predictable irrationalities and biases in human behavior. This field draws on constructs from behavioral economics and psychology to attempt to change behavior. It includes things like incentives, defaults, and commitment devices, and has been used successfully to promote weight loss, smoking cessation, and other behavioral beneficial health behaviors. In this study, we focused on two different behavior change levers from behavioral science. The first was priming, which is when a stimulus, like an image or a smell, subconsciously or indirectly stimulates another behavior. The second was social influence, which is when a person's emotions, opinions, or behaviors are affected by others. For example, studies that use popular opinion leaders are often attempting to use social influence to change behavior in this way. We hypothesized that a low-cost intervention based on the concepts of priming and social norms might be a good strategy in settings where the typical HIV patient clinic experience is characterized by long wait times, where there's anxiety about negative provider interactions and stigma, where patients are often worried about disclosure, but at the same time, they also value the clinic as a source of social support from providers and fellow patients. So our goal was to evaluate the feasibility, acceptability, and short-term effectiveness of an intervention based on social norm and priming to improve adherence and retention and care among people living with HIV infection in Tanzania. The study was conducted at 2 primary care clinics in Shinyanga region. Patients were eligible for the study if they were at least 18 years of age, were living with HIV infection, and were on ART at study initiation. To develop the intervention, we used patient-centered design, which is a creative, empathetic approach that draws on ethnographic methods and relies on rapid prototyping and user testing. This involved the collection of data from household and clinic observations, photo-based interviews, and in-depth semi-structured interviews with patients and providers. We used data from these approaches to identify patient segments, and we created corresponding journey maps. These are tools from the private sector that are often used to guide business and marketing innovation, and they describe a group's perception of health, barriers to ART adherence, and potential interventions. Here's an example of one of our patient segments and our fictionalized patient personas. This No Tomorrows segment describes young people who are asymptomatic and primarily motivated by social aspirations like marriage. Ideal interventions for this segment are discrete, impart or support their immediate social goals, and impart a long-term perspective on why adherence to ART is important. For each of our patient segments, we also created a corresponding journey map. This describes stages in the HIV treatment experience and areas that would be ideal places to intervene. We used these insights to develop a combination intervention, which had 3 components: the prime, take-home components, and a clinic-based component. The prime was a locally recognizable image of the baobab tree and the local idiom that together we can hug the baobab tree, which is a statement about working together to achieve a common goal. The prime appeared on every component of the intervention. Patients also received a useful take-home item that featured the prime and was intended to remind them about the clinic in between their infrequent clinic visits. One group received a calendar with images featuring health and vitality, and the others received a pillbox with the approximate dimensions of a feature phone so that people could transport their medication discreetly without others asking about it. And finally, there was a clinic component, which was an interactive poster that was displayed in the clinic. When patients attended 3 consecutive appointments, they were congratulated and they were offered a sticker to place on this poster, which was publicly displayed in the waiting room. As the stickers accumulated over time, it provided visual feedback that adherence to ART is normative. And this accumulation of stickers also completed an image, which was changed regularly. We evaluated feasibility and acceptability with an anonymous survey of clinic attendees at baseline and endline at 6 months. And we evaluated short-term effectiveness with a quasi-experimental 6-month pilot study. In this study, the intervention was implemented every 2 weeks for 6 months. And given that most patients followed 30 or 60-day visit frequencies, they were typically only exposed to the intervention or the standard of care during the study period. We evaluated the association between the intervention exposure and the outcomes after waiting to adjust for our sampling strategy. The primary outcomes were retention and care at 6 months and ART adherence at 6 months, measured with the medication possession ratio, which is the proportion of days that an individual is in possession of at least 1 ART dose. And we calculated MPR at an adherence threshold of 95%. A secondary outcome was appointment adherence during the 6-month study period. Here are the results of the feasibility and acceptability survey, which was conducted with 405 patients. These data indicate that compared to baseline, patients experienced increases in staff support of their treatment goals and their life goals, the perception that other patients support them, the perception that other patients are being adherent, and we saw an increase over baseline from the likelihood that patients were very satisfied with services and care. Data from open-ended questions indicated that patients found the interactive poster very acceptable, and actually they quite enjoyed being congratulated by the healthcare staff on their achievements of coming to clinic appointments on time. For the quasi-experimental pilot study, we randomly sampled patients from medical records according to whether they were exposed to the intervention or not. And this included 438 patients with a purposeful oversampling of intervention patients. These groups were balanced at baseline with similarities in age, gender, time on ART, and appointment attendance at baseline. Here are the results of the pilot study. We found that people living with HIV infection who were exposed to the intervention were more likely to be in care 6 months after the start of the study compared to those who were in the comparison group. We also found that patients who were exposed to the intervention were slightly more likely to have achieved MPR 95% at the end of the study period, although this result was no longer statistically significant after we adjusted for covariates. And there was no difference in mean appointment visit attendance between the two groups. So this pilot study has several limitations. The most important one is probably that it was conducted at 2 facilities in Tanzania, so future studies would have to determine the generalizability of this approach. The intervention was evaluated as a combination package, and we did not determine the individual effectiveness of individual components. In addition, we had imperfect measurement of the intervention exposure because it was implemented every 2 weeks during the study period. However, we also conducted a sensitivity analysis using an instrumental variable approach and the exact dates of patient visits, and we find that the results are similar, which suggests that the intervention may have improved retention and care and potentially improved ART adherence during the study period. And lastly, we did not measure viral load, but we know that MPR is highly correlated with short-term viral suppression. So we conducted a pilot study of a novel intervention using the concepts of priming and social influence to tackle the problem of poor ART adherence and retention and care in Tanzania. Our novel approach combines design thinking to apply tools from behavioral science to this problem, coupled with an evaluation to determine its effectiveness. Our overall goal was to address behavioral gaps by improving the patient experience. We found that the low-cost intervention was feasible and acceptable to patients and staff, and that it was associated with temporal improvements in perceived support from staff and other patients and satisfaction with clinical services. We also found that the intervention may have been positively associated with increased retention and care and potentially MPR 95% over the short 6-month follow-up period. Now, although this intervention is very specific to this study population, the design and evaluation approach could lead to locally relevant solutions in different geographic areas for different health outcomes. And in this way, our intervention is intended to enhance the HIV care continuum and potentially the effectiveness of Treat All. So with that, I'd like to acknowledge my co-authors, and I welcome any questions. Thank you.
Thank you very much, Sandra, for that presentation and for keeping to time. The floor is now open for questions. Okay. We'll start from the mic on the left here. Go ahead.
Hi, David Wall, UNC. This is really an elegant study. Do you think you might have had different results if you had taken people who weren't sort of already pre-selected for maybe retaining in clinic, so maybe new starts or recent starts of ART or care?
Oh, should I wait?
Okay, we'll take a couple more at the back. Is there a question? Yes, let's.
Hi,
Go
this
ahead.
is Susan Strasser from ICAP at Columbia University. My question is for the speaker or the others who've spoken before her. If any of you have used measures around hope as a proxy for a personal sense of well-being. I know that Snyder's definition of hope uses agency, so the feeling that you can make something happen, and pathways, knowing how to get things done. And it seems like, based on the work of the 3 that presented thus far, would be a meaningful indicator to add.
Okay, we'll take the question on the right side. of the
Thank
room.
you for your presentation. This is Namwenga Chintu from Population Services International in Zambia. I wanted to find out, did you look at dosing exposure and whether this had an impact on your outcome of adherence? Thank you.
Are there any other questions in the room? Okay, my co-chair has.
Yes, I have a question. Thank you. Who delivered the intervention?
Okay, go ahead,
Okay.
Sandra.
Thank you for those great questions. The first question for Dr. Wool about agree. I would love to do this focused on ART initiates. This was just a pilot study, but I think that there are some important windows of opportunity at the time of treatment initiation to bolster people's willingness to come to the clinic. So I think something like this would be ideal for a situation. And I completely acknowledge that we are using a biased sample because these folks are already in care. To the question about hope, I think this is a great idea. We did not mention this, or we did not focus on this in this study, but I agree that hopefulness and people's how they feel about their future is sort of emerging in multiple studies as an important factor. So I couldn't agree more, although we didn't look at that in this study. The question about exposure to the intervention. So we actually did some sub-analyses where we looked at this. And to be totally honest, it actually turned out to be quite complicated because people have many different levels of exposure to this intervention. So they could have sort of the weakest level of exposure, which is they just come to the clinic and they see the poster, and that's it. Whereas other people might have been earning stickers several times over the course of the intervention. Maybe they received a take-home component that they used actively. And so although we did some sub-analyses, I don't feel quite confident enough in them to present them today. But this is definitely something else for us to look at. So thank you for that question. And who delivered the intervention? The pharmacist delivered the intervention. And that was a very purposeful design. We wanted to design something that was implemented by the healthcare workers themselves. So we worked really closely with the pharmacists because they're at least at these two clinics, the pharmacists are the last point of contact before people leave. So we really wanted that to be a positive experience. Thank you.
All right, thank you very much, Sandra. And I would like to hand over to my co-chair for the next the next speakers.
Well, thank you very much, Dr. Apollo. And I'm Wafa El-Sadr from ICAP at Columbia University. I'm honored to co-moderate this session. Our next speaker is Margaret Proust, and she is from the Clinton Health Access Initiative. And please go ahead.
Thank you.
We welcome you.
So I'll be presenting on behalf of our team here from the Clinton Health Access Initiative and the Malawi Ministry of Health. So multi-month prescriptions are one of the earliest and most basic forms of differentiated care. And in Malawi, it's been part of the national ART guidelines that stable patients should receive 3-month refills. And that was put in the national guidelines in 2008. And that is as opposed to unstable patients, which receive 1-month refills. But despite this having been a policy in Malawi and elsewhere for many years, there's little information available about how these types of policies are being operationalized. And so we set out to understand how patients were being differentiated and whether it was being done accurately, and what types of issues might be leading to inaccuracy and differentiation of stable and unstable patients. So we conducted a process evaluation across 30 public sector ART sites in Malawi. They were purposefully selected sites to achieve diversity across different facility characteristics. And as you can see from the map, we sampled a large number of facilities in the southern region, and that is because the study was also looking at 2 other models of differentiated care, community ART groups, and fast-track refills or 6-month appointments. And I won't be talking about those models today, but they are only being implemented in the south, and so that's why we sampled a large number of facilities there. So most of the data I'll be talking about today comes from a review of patient records. 14 of our facilities were using paper-based records, and so we randomly sampled adult patients. And the rest of the facilities were using electronic records, and so we were able to analyze data from all patients. We also conducted a survey with all health workers working in the ART clinics. It was orally administered. And then we conducted qualitative interviews with the ART clinic in charges. All of the data was cleaned and analyzed using Stata, and everything that you'll see today has been weighted and clustered to deal with the facility level analysis. And the qualitative data was analyzed using transcripts from audio files that were thematically coded by a team of 3. So what you can see here on the left is the list of criteria that are used in Malawi to determine which patients are stable. Many of you in this room may be aware that in 2016, the WHO released guidance on how to define a stable patient. This data was collected in February to April 2016. And so it was before those guidelines were released, and we used the Malawi Ministry of Health guidance. So as you can see here, the reasons that patients were, the most common reasons that patients were considered unstable or ineligible for multi-month refills is that their time on ART and having unsuppressed viral load. In our study, we only collected data on adults. And the adherence data in patient records was inconsistently collected, and we felt that it wasn't usable for this study. So we found that 86.4% of patients were stable and eligible for 3-month refills, but that number is likely somewhat lower due to poor adherence among some patients. And we also found that 69% of patients were receiving refills of 3 months or more. And so what we were interested in is understanding whether the patients who were eligible for 3-month refills were also the ones who were getting those 3-month refills. So among patients who were eligible, we saw that about 73% of those patients were receiving 3-month refills. And among the 27% who were not receiving 3-month refills, that may be a missed opportunity to improve efficiency or reduce the burden on those patients for care. But on the other side, among the patients that were not eligible or were classified as unstable, 42% of those patients were receiving refills of 3 months or more. So in our in-charge interviews, we asked health workers, we did not yet have this quantitative data, but we asked health workers about what types of issues may cause patients to, sort of eligible patients to not receive 3-month refills. And the kinds of responses that we heard had to do with health worker knowledge, provider concerns around whether patients would be adherent and would continue to come to the clinic on multi-month refills. Also, sometimes when facilities have low drug stocks, they're unable to provide 3-month refills. And additionally, as I mentioned earlier, some patients may have poor adherence, but that wasn't captured in our data. On the other side, patients that are unstable or not eligible for MMS may sometimes be included because health workers are not aware of what the criteria are. Or because health workers are trying to reduce their workload in the clinic. We also saw that there were cases where patients had previously been eligible but had transitioned, maybe on a recent viral load test, had transitioned to being ineligible, and their refill amount was not changed, or just special patient requests for longer refills. So we also looked, now this is among the 42% of patients that were not eligible but were receiving 3-month refills, we looked at which characteristics caused them to be ineligible. And so as you can see here, the most common reason that these patients were ineligible was because they had an unsuppressed viral load. We also asked, in the health worker survey, we asked, as an open-ended question, we asked health workers to tell us what the criteria were for a patient to be considered stable. And so on the bottom, this represents the percentage of nurses and clinicians, which are typically the people that are making the determination about stability and writing the prescription. This is the percentage of nurses and clinicians that mentioned each of the criteria. And so you can see the viral load numbers are quite low, but certainly not the lowest. But this does indicate that there are some knowledge gaps among health workers. We also wanted to look at whether there were differences in patient differentiation across the 30 facilities in our sample. So each of the dots here represents one facility. And on the horizontal axis, this is the percentage of patients that were eligible and receiving 3-month refills. So we want that number to be quite high. And then on the vertical axis, we have the percentage of ineligible patients receiving 3-month refills. And so we want that number to be quite low. So ideally, all of the patients would be falling sort of in the corner over, or all the facilities would be falling in the corner over there. So they would be falling in the green area here. But as you can see, we have a large number of facilities that fall right along the midline of this chart. And so what that's telling us is that in those facilities, a similar percentage of eligible and ineligible patients are receiving 3-month refills. Or in other words, health workers are not differentiating based on the differentiation criteria. And that relationship between the ineligible and eligible patients receiving 3-month refills was statistically significant, which we would not expect to be the case if differentiation was accurate. In a final piece of results, we also looked at whether there were characteristics at the facility level or individual level that could tell us about where differentiation was less accurate. At the facility level, we did see that in the southern region, facilities were slightly more likely to misclassify patients. And at the individual level, males were less likely to be misclassified. And as people get older, they were slightly less likely to be misclassified. But I think we should keep in mind that even though these are very significant results, we had a lot of patient data here, and so our odds ratios are not very large there. So we didn't think that those were very strong trends. We also looked at other measures of diagnostic accuracy. These results show the total misclassification, but we also looked at likelihood ratio, diagnostic odds ratio, and the false positive rate, and found similar results with all of those measures. So in conclusion, even though multi-month refills are being implemented widely in Malawi and so many other countries, the results from this study show that patients are not being differentiated consistently according to the differentiation criteria. And our results did not show, very strong trends in terms of what might be the predictors of misclassification. And I think what this tells us is that this is a problem this is an issue that is taking place, across populations and across facilities and should be addressed at a national level and in a comprehensive way. So we recommend that there be more health worker training and support to accurately differentiate patients, and this would be applicable not only to multi-month refills, but other forms of differentiated care that are for stable or unstable patients. We, also as electronic medical records are being rolled out in many contexts, this is an opportunity for automated checks in the system that can prompt health workers as to which patients may be eligible, or as countries revise paper-based patient records, differentiated care could be taken into account. And finally, in this study, we did not look at patient outcomes, and I think an important sort of future area for research would be to understand the patient outcomes among ineligible and eligible patients that are receiving refills of 3 months or more. So I'd like to acknowledge all of the other investigators on this study. And I'll also mention that in this study, as I mentioned earlier, we looked at 2 other models of care, and we also collected data on patient and health worker perspectives and cost of various models. And some of those results are available in the poster presentation tomorrow.
Thank you very much, and we'll take some questions. I can see somebody coming up to the mic, please. Oh, 2 people, great.
I'm Dr. Ruth Labode, a Member of Parliament from Zimbabwe. I'm concerned, especially, I'm so glad that you talk about this because it is happening also in Zimbabwe, but mostly within SADC because of mobility. You sent people come back home because they're illegal immigrants and working somewhere else. Mostly it has to do with cross-border workers who are illegal where they are. And because those countries are refusing to treat them, then you give them those 3 months stock and hope to come, mostly for HIV and for ART and TB drugs. So I really wondered whether among those who are eligible, because that is the eligibility specifically for a district called Cholocho, you have to be working somewhere else and you are illegal. You cannot come home frequent for some reason or another. Thank you.
Thank you. One more question there, and then we'll come here. Go ahead.
Thank you. Florentino Badial from Mexico City HIV program. We have a similar strategy. We identify those who have been 1 year on treatment and are virologically suppressed with a green sticker. And but you made me raise up to a couple of questions. First question is why use only first-line regimens as a criteria to help them get into, or to let them get into this kind of program, since maybe they are on second-line treatment because of adverse effects or whatever, or because they have so hard time coming to the clinic every month to pick up their pills, and that's why they're on a second-line regimen. And now they can't get into a program, you know, for less visits to the clinic, which makes me think also
get to the second question.
Yeah, sorry. No, to the second the second point, which is virologic suppression, and for patients who have, or persons who have such a hard time coming to the clinic, and maybe that is the reason why they have not virologic suppression. And are we doing something else besides getting them to pick up their pills, so to reinforce adherence, or only making them come to the clinic pharmacy, and that's it?
Great, thank you. I think quick questions. We'll take 2 more, please, but very quick and quick answers. Go ahead.
Thank you. My name is Santiago Ferro. I'm from Canada. And I'm pretty sure in the criteria that the Ministry of Health in Malawi had to be eligible included a viral load. So my question is, did you look at the timing of the reception of the results of the viral load? In many places is quite delayed, so that might have accounted for some of the eligible not being eligible and vice versa.
Thank you. Quick, please. Yes, thank you.
Hi, my name is Valériane Leroy from INSERM in France. Maybe I missed it, but please could you state what you have done regarding eligibility criteria for pregnant women, and also why did you exclude from these eligibility criteria, include those youth age from 19 to 25?
Thank you. Go ahead, please, Margaret. Quick.
It'll be quick. So a lot of these questions pertain to the eligibility criteria, and again, these are the national criteria used by the Malawi government. So going in backwards order, for pregnant women, while pregnant women are not eligible for some other models of differentiated care in Malawi, they are eligible for 3-month refills. For viral load, we looked at the information that was available to the health worker at the time that the refill was provided. So we were looking at their most recent viral load test that was on record at that time. In terms of the regimen that patients were on, In Malawi, patients who are on a second-line regimen are eligible for 2-month refills, and we did not look at that data here. But in the recent WHO criteria, I believe that patients on second-line treatment are recommended to be eligible for 3-month refills.
Great.
And finally, in relation to people who are traveling or migrant workers, when I mentioned that health workers say that they get a lot of patient requests for 3-month refills, that is often the reason that they are traveling for work-related reasons. And so I think that is behind what's going on with a lot of those patients. But what's important to remember is that we still see that 77% of these ineligible patients have unsuppressed viral load. And so even with migrant workers or patients that are traveling, we have to find a way to to get them to a place of being virally suppressed.
Thank you very much. Appreciate it. Sorry to rush you, but we have 2 more presentations. Now let's welcome Dr. Maria Kim, and she's a professor of pediatrics, retrovirology, and global health at Baylor College of Medicine. Welcome, Maria.
Hi. So again, Dr. Maria Kim. I'm actually living in Malawi and with Baylor Children's Foundation, Malawi. Okay. I'm going to be presenting today on multi-month prescription of ART amongst children and adolescents, experiences from the Baylor International Pediatric AIDS Initiative in 6 African countries. No potential conflicts of interest to report. To improve ART coverage and help reach the 90-90-90 targets, we need differentiated approaches to care. Potential models include reduced frequency of clinic visits for stable patients. Unfortunately, there's a paucity of data regarding the impact of differentiated care models, including reduced clinic visits, on pediatric and adolescent outcomes. Baylor International Pediatric AIDS Initiative, otherwise known as BPI, has centers of excellence in Botswana, Lesotho, Swaziland, Malawi, Uganda, and Tanzania. These COEs provide free, comprehensive HIV care for HIV-infected children and adolescents. Our objective was to evaluate the feasibility and describe the experience of delivering multi-monthly ART prescription schedules by conducting a retrospective analysis of clinical outcomes and comparing monthly MP with multi-monthly ART prescription schedules, MMP, for children and adolescents 0 to 19 years of age attending BPI COEs. MMP was introduced at each COE in line with national policy. However, the decision to switch to MMP was made on an individual patient basis and varied by provider and facility. Patients were transitioned to MMP when deemed to be clinically stable and ART adherent, typically after 6 to 9 months of monthly prescriptions. Clinically stable was defined as an improving CD4 count, undetectable viral load, and minimal HIV-associated morbidity. ART adherence was defined as a pill count of 95 to 105% by pharmacy refill data. We conducted a retrospective review of electronic patient medical records in 7 urban clinics in 6 African countries. We reviewed the records of patients 0 to 19 years of age initiated on ART from January 1st, 2003 to June 30th, 2015, and the data set was closed on June 30th, 2016. Patient visits were classified as either monthly or multi-monthly based on the number of days between scheduled clinical visits. MMP was defined as 56 to 180 days. Outcomes were defined as follows. Adherence, a pill count of 95 to 105%. Loss to follow-up as recorded in the EMR. CD4 count greater than 350 for patients greater than or equal to 5 years of age. and a CD4% of greater than 25% for those less than 5 years. Viral load was undetectable versus detectable, and undetectable defined as less than 400 copies per ml. And these outcomes were compared between MP and MMP patients by 2 sample tests for binomial proportions. Mortality was compared by log rank test, and to avoid immortal time bias, MMP patients contributed person time to the MP group between ART initiation and the start of MMP. In total, we reviewed 22,658 patient records. 2,186 records were excluded because these had less than 12 months of follow-up data when the dataset was closed. We had 20,472 patient records included in the analysis. 74% were 0 to 9 years of age, and 26% were 10 to 19 years of age at ART initiation. 26% remained in MP, and 74% were transitioned to MMP. The data was analyzed as intent to treat. The results. As compared to MP, MMP patients had lower mortality and loss to follow-up, as well as superior ART adherence and response to ART by CD4 and viral load measurements. Mortality was 2.08 deaths per 100 patient years in the MP group, as compared to 0.45 in the MMP group. And the analysis by country and by disaggregated age groups yielded broadly similar findings as follows. By country, mortality was significantly lower in the MMP as compared to the MP group. Loss to follow-up by country, a smaller proportion of those in MMP were lost to follow-up as compared to MP. Survival by Kaplan-Meier method was also better in the MMP versus MP group. For each age group, although loss to follow-up and mortality varied, they were still lower in the MMP versus MP groups. By country, adherence, CD4, and viral load were better in the MMP versus MP group. And again, by age group, adherence, CD4, and viral load varied, but were better in the MMP versus MP group. So a few limitations. By definition, patients in MP remained on monthly prescription schedules because they were deemed to have either adherence or clinical issues. So it's not surprising that their clinical outcomes were worse than MMP patients. We did consider comparing clinical outcomes of patients before and after entry into MMP. Unfortunately, due to insufficient data, we were unable to conduct a meaningful comparison. And all patients attended BPI COEs, which were comparatively well-resourced, and this may limit generalizability to other health settings. However, the BPI clinics are very busy, seeing upwards of 100 patients daily, and so there may be some ability to translate this into other busy health settings. So in conclusion, this analysis of more than 15,000 children and adolescents from 6 African countries demonstrates that a transition to multi-monthly prescription schedules was feasible and safe, with evidence of positive health outcomes in terms of immunologic status, ART adherence, virologic suppression, retention, and mortality. So I'd like to thank the BPI network, the leadership, healthcare workers, data and admin staff, USAID RAP program, as well as USAID Washington, and the technical support to PEPFAR programs team, which funded and supported this study. And finally, the children, adolescents, and families who inspire us with their perseverance and courage. Thank you very much.
Thank you. It's great. We'll open the study for questions, this presentation for questions. I see Nancy going towards the microphone.
Great presentation. My question is, when were the parents on the same schedule as the kids, especially for the babies?
Okay, I think, yes, please, go ahead.
Hi, Anna Hurd from 3IE in Washington, D.C. So you've basically explained that the two patient groups that you started with are completely different. You're probably starting out with totally different adherence and outcomes in the two different groups. So how can you say anything about the outcomes that you found from this study when you don't have a before and after either?
Yes, please, go ahead. Last
The beauty, Haruna Jibril from Botswana, Ministry of Health. You see, we from the ministry, from program side, we look forward to such studies so that we can then roll them out to make some sense in terms of our programs. But I know Baylor very well, and you know, you are not only resourcing the number of patients that you see, but you are resourcing in terms of the quality of the health manpower that you have in terms of number and skills. So for me, it's wonderful. I could recommend it to the government, but because there's no way we can have that kind of degree of quality of resource, especially human resource, for us to roll out to a national program.
Okay, thank you. Go ahead, Maria.
Thank you very much. So to the first question regarding the parent schedule, some of the COEs have a family-centered clinic and others do not. So we did not analyze parents' prescription schedules. And at the centers where the parent schedule is paired with the children's schedule, I don't know if the refill schedule was timed, but I would assume so. The other two questions, excellent comments and questions. So yes, we tried to do a before and after analysis, which wasn't possible because of too much missing data in the before group. And the two groups are inherently very, very different. The MMP group, by definition, were patients who were doing well. So we weren't surprised that they continued to do well. I think perhaps the main take-home from this isn't actually the comparison, but that the MMP group continued to do okay. I think in our previous presentation, when we had presented at the Peds Virology Conference before this, a suggestion had been made to do longitudinal analysis of the MMP group, which we are definitely considering at this point. And then generalizability, yes, I do recognize that as a limitation.
Well, thank you very much. Very interesting study. Thank you. We're going to move on now to our last presentation, which is going to be delivered by Colleen Hanrahan, and she is from the Johns Hopkins Bloomberg School of Public Health. Welcome.
On behalf of my co-authors, thanks for the opportunity to present the findings from a randomized control trial of community versus clinic-based adherence clubs for stable ART patients in South Africa. Adherence clubs are groups of 25 to 30 patients who are stable on ART. They meet for counseling and medication pickup, usually every 2 to 3 months, and they have an annual medical visit. And this has been developed as an intervention in order to facilitate task shifting and decongest busy clinics and allow clinicians to focus their time and energy on patients who require more complex care. There's been 2 large observational studies done in Cape Town that show that adherence clubs promote retention and care and viral suppression compared to the standard of care in the clinic. And I show here some of their impressive reductions in loss to care and virologic rebound from these studies. Why were we focused on the question of community versus clinic-based clubs? Well, there's been an increased interest in task shifting to community-based HIV care. There was a systematic review done looking at comparing the outcomes from community versus clinic-based interventions, although it wasn't specific to adherence clubs, and this suggested that there are at least comparable retention and patient outcomes when clinic-based interventions are moved to the community. But we still imagined a number of factors at play that you can kind of consider would go in maybe either direction, including stigma, convenience to the patient and cost to the patient, access to other types of health care, and several other factors. So the primary objective of our study was to compare the effectiveness of community versus clinic-based adherence clubs on retention and club-based care and viral suppression. We conducted an unblinded, open-label, randomized control trial. Participants were receiving care at a clinic. They were randomized to receive either clinic-based or community-based adherence clubs, and randomization was stratified by the area of residence. So we started 2 clubs per residential area per month. 1 club was in the community and 1 club was based at the clinic. We did this for 12 months starting in February 2014 and followed participants for 24 months. The study was set at Vikopen Health and Welfare Center, which is located in northern Johannesburg. It's there with the blue symbol. This is a high-volume primary care clinic. And we chose 5 of the largest communities that it serves to be include participants in this study. That's Deep Sud, Kaya Sands, Cosmos City, Four Ways, and Musawawa. These vary from between 5 and 30 minutes from the clinic by public transport, and they consist of a mixture of both informal and formal housing types. We based the adherence club intervention on the MSF model and in fact used a lot of their tools in the development of our clubs. Each club had between 25 and 30 participants to begin with. It was run by a lay HIV counselor and supported by a primary health care nurse. Clubs met every 2 months. There was a blood draw every 6 months for viral load, and they had an annual medical visit at the clinic. At the clubs, they were screened for pregnancy, TB symptoms, and blood pressure if they were hypertensive. We held the community-based clubs at different venues in the community, such as churches, the community center. We referred patients back to the standard of care when they missed a club visit and didn't pick up ART within 5 days. When they had a viral rebound, defined here as a viral load greater than 400 copies per mil, or 2 viral loads within the 50 to 400 range. When they developed any excluding comorbidity that required additional care at the clinic. When they became pregnant, they sent a friend to pick up 2 times in a row, or if they voluntarily chose to refer themselves back to the clinic. We enrolled adults over age 18 who have been on the same ART regimen for the previous year and who are virally suppressed as previously defined. Our exclusion criteria centered around excluding participants who needed more complicated care, more attention in their care at the clinic. Our primary outcome was retention and club-based care, which included being virally suppressed, since you were referred back to clinic-based care if you had a viral rebound. This comparison was, our primary comparison was done using Kaplan-Meier survival curves compared with the log rank test. And then in a secondary analysis, we used univariate and multivariate Cox proportional hazard models, looking at the risk of loss from club-based care. The clinic sees about 2,000 patients on ART per month. So we pre-screened these files in order to identify potentially eligible patients who were then screened more in depth by a clinician. We screened 1,202 potentially eligible patients, of whom 30% were ineligible, mainly due to comorbidities and not being virally suppressed. We randomized 846 patients, 434 to community clubs, 412 to clinic clubs. We then took a viral load at baseline to confirm that they were virally suppressed, and we lost an additional 8 to 9% here who were not virally suppressed at baseline. Therefore, we ended up with 399 participants in community clubs and 376 in clinic-based clubs. These are the baseline characteristics of our participants. They were on average 38 years old. 2/3 of them were women. The majority of them were on a fixed dose combination. And the other characteristics are fairly balanced between the 2 arms, with a little suggestion that there was a little imbalance in unemployment and perhaps a higher CD4 count in the community club participants. So for our primary outcome, retention in club-based care, we found that participants in clinic-based clubs had higher retention in club-based care and viral suppression compared to those in community-based clubs. We retained 57% of participants in club-based care at the clinic compared to 48% in the community. Overall, combining the two groups, we retained 53% of our participants, and they were virally suppressed 24 months in any type of club-based care. When we looked at the reasons for loss from club-based care, the majority of participants were lost because they didn't come to the club visit and pick up their ART either at that visit or within the allotted 5-day window for missing a club visit. There were some viral rebounds, although overall this, over the entire cohort, this was about 6 to 7% of participants. And there were a few people who chose to go back to care at the clinic who developed comorbidities or required a regimen change during this study period. When we looked at this using a multivariate Cox proportional hazards model that also controlled for sex, age, employment status, and baseline CD4 count, we found that participants who were in community-based clubs were at 44% higher risk for loss from club-based care compared to those in clinic-based clubs. We did a post hoc analysis looking at retention in any ART care. That means either you retained in your club-based care, or if you were referred back to the clinic, you retained in clinic-based care and virally suppressed. Here we found that there persisted to be a lower retention in care in the community. 88% were retained in care over 24 months in any ART care compared to 93% at the clinic. Though this result was not significant in our multivariate analysis, it still gives the same inference as our retention in club-based care. In conclusion, we found that 24-month retention in club care was higher among participants in clinic-based clubs versus community clubs. Overall retention in the adherence club intervention was relatively poor at 53% overall. The most common reason for returning to clinic-based standard of care was missing a club visit. And viral rebound and voluntary withdrawal were rare. And these are lower retention and care findings than those that were published from Cape Town. And we've thought a lot about why this may be. And there could be some differences in the timing of the outcome that was assessed, the actual outcome assessed, retention in ART care versus retention in club-based care. The two studies from Cape Town were observational studies that weren't randomized, as evidenced by this quote from the discussion of the Luque Fernandez study, showing that only some stable patients were offered participation based on their enthusiasm for the model, on the clinician's enthusiasm, and other differences in approach, such as the patient population, eligibility criteria, so forth. Some limitations. This was 2 years of follow-up as a proxy for what's intended to be a lifelong intervention, so we may have an underestimated retention here. Or overestimated retention, sorry. Those dropping out of care at the study clinic may have sought care at another clinic, so we could be underestimating retention in any ART care. Treatment assignment was unblinded, and it could have led to some form of bias in how participants were referred back to the standard clinic-based care. And this was in a highly urbanized setting in South Africa, middle-income country, so may not be generalizable to other settings and countries. In terms of implications for public health, I think we see here that we should be cautious about assuming that clinic-based interventions automatically translate into the community. Also, looking at retention in club care itself, rather than just any ART care, is an important metric by which to evaluate adherence clubs' success. And we need a better understanding of which aspects of adherence clubs are associated with success and what exactly the drivers were that led to higher retention in clinic-based care. Thanks very much to all of the study participants, the staff at Witkoppen Health and Welfare Center, our community partners, and our funders at USAID. Thanks.
Thank you. Thank you very much. We have time for a couple of questions. Yes, please.
Yes, I'm particularly interested in you asked what one of the reasons might be that we're seeing this difference. And I think that by randomizing the patients, we're not giving patients a choice as to the location of where they receive their services, which is kind of one of the principles of differentiating care. By already randomizing them, we may be forcing people to receive their care in the community when they're not ready. And if you look at your Kaplan-Meier, you actually see that there's a sudden drop-off. It looks quite early on where they start splitting. And perhaps that's your patients that say, I don't want to receive my care in my community. I also challenge whether it's really that important for us to be looking at retention in club care if the patient is retained in clinic care. And the two papers that you refer to both only reflect retention in care, because that's really what we're interested in, whether it's in the particular model or not. Perhaps the model wasn't suiting them.
Thank you. Yes, please.
Thank you very much. I thought the study was in an urban setup. And in South Africa, clinics are within walkable distances, in fact. So club treatment or club as an initiative should not be ruled out in a rural setup where distances are between 15 to 20 kilometers. Obviously, if I lived in an urban setup, I would say, why should I join a club instead of going to the clinic, which is less than 1 kilometer or a kilometer from me? I think that's where the whole thing, we should not generalize and rule out that community initiatives may not have a good impact. Thank you.
Thank you. Question in the back there. Quick, please.
I was wondering if you looked at all at internalized stigma or perceived external stigma, because a lot of the reasons why we move adherence clubs out of clinics into communities is because young people feel stigmatized in the clinical setting. So just curious if you looked at that at all.
Okay, last question here, and then Dr. Apollo has a question. Please go ahead.
I just wanted to ask, how would you classify people who wouldn't go for the talking and who would just go for picking up drugs maybe 2 days later without doing the talking in the club?
Okay, Dr. Apollo?
Thank you. I just wanted to find out whether the service package that was offered in the clinic-based versus the community-based clubs were similar, because you noted that there was a primary health care nurse who also provided some inputs. Were they also providing the same services to the community-based clubs?
I actually had a question. I may have misled this, but what was the viral suppression at 24 months? Was it 53%? Is that correct?
It was a combined outcome of retention and club-based care.
It's both. I see. That's the primary outcome. Okay.
Yeah.
Go ahead, please. The question.
Okay. So let me see. To start with the question, thank you for these questions on no choice. It's true that the randomizing, the intervention didn't necessarily give people a choice. We did perform an annual acceptability interview with our participants, and we also did some qualitative in-depth interviews with participants who were retained in care and those who were referred back to standard of care. And the analysis of those qualitative data are ongoing. I can say that in general, people were very happy to be in either a clinic-based club or a community-based club. They identified benefits to being in either or both of them. Of course, they didn't have the choice, as you point out, and they didn't experience the other intervention to see whether they might like that better. But I still think that there are some benefits to randomizing that can't be denied. And now to your second question about why is retention in club care important, I'm going to respectfully disagree with you and say that I think it's very important. These are logistically challenging interventions to run. They're complicated, and if they're not working, if they're not the reason that people are staying in care, I would just ask, why are we doing them? So I think that looking at whether you're running adherence clubs and you're keeping people in your intervention, I think that's a vitally important question to ask. Your question about rural clients, I certainly have nothing to really offer from this study to say about rural clients, and I don't want to go so far as to say we should or shouldn't offer adherence clubs there. I think it's a valuable and powerful tool for attention and care, and I think there need to be study-specific or setting-specific studies to inform that. How did we characterize people who missed a club visit, didn't come for the talking and just came for the pickup. You could do that according to the rules. That could happen that you did that. You couldn't do it 2 times in a row. And so we kept them in the study and kept them in the club-based care as per the rules that I think we followed the MSF model on that. The service package was identical between the two arms. The nurse didn't attend the club visits unless it was a blood draw visit. She monitored them clinically. She followed up on participants who had an elevated blood pressure, who were hypertensive, or who had TB symptoms, and then she would follow up on those participants through investigation of TB symptoms and then returning them back to the club when they were finished being a TB suspect. So, thanks.
Well, thank you very much. I think you'll agree with me that we've had some stellar presentations today, and it's really good to see all of these models now, differentiated care models, are being evaluated rigorously and studied, and we're beginning to get some very important answers to some of the critical questions that hopefully will inform programs down the line. So thank you to the audience, and thank you to the presenters, and thanks to my co-moderator.